Great. Good morning, everybody. Welcome to day 2 of our Spring Representative Assembly. It's great to see you all this morning and hope you've recovered from the preferred coronation in the last 24 hours that we all attended last night. I would like to start with some housekeeping items. At approximately 10 a.m., we are having an in-camera session for an MCRC update. And so this is for SMA members and the staff only. At that point, the virtual streaming will be stopped as well. And there are door prizes at the end of the meeting, so you have to be in person to win one of the door prize. So that's incentive for you to stick around till the end to see if you can get one of these prizes from the SMA. There are evaluation forms on all of your tables. The SMA does take into account any of our suggestions, and to help improve this meeting, we would please ask that you fill out the evaluation forms. And if you haven't already put it in your calendars, November 3rd and 4th, we're going to be back here for the Fall Representative Assembly at the Sheraton Cavalier Hotel. So before we get started on the College of Physicians and Surgeons report, I'd like to ask Dr. Jevry, past president of the SMA, to come up and say a few words.
Thank you, Mary. Good morning, everyone. Before Dr. Beggs gives his report and takes questions, I wish to thank, on behalf of the SMA, Dr. Karen Shaw. As many of you know, Dr. Shaw is retiring from her position as the Registrar of the College of Physicians as of July. We appreciate Dr. Shaw's work over the last 24 years. She served as the Deputy Registrar for 10 years and as the Registrar for 12 years. She also served on the Council as well as the President of the CPSS Council. Dr. Shaw has been a dedicated and untiring leader of the CPSS. She's guided the organization through very difficult cases as well as organizational change. During her many years of service, she's always led with an eye on what's important to both the patient but also the practice of medicine. And we are grateful for her work. On behalf of the SMA, I want to thank Dr. Shaw again for your many years of service, and you have definitely left the CPSS better than you found it. I'd ask everybody, please join me in a round of applause thanking Dr. Shaw.
Is Karen here? She's in the dining room. You guys got to clap louder so she can hear it. Yeah, okay. A standing round of applause when Karen comes in. So I'd like to carry on with the CPSS report and invite Dr. Alan Beggs, the president of the CPSS, to the stage. Dr. Beggs is an orthopedic spine surgeon in Regina and has been working there for the last 17 years. He's also currently the SMA Orthopedic Section Rep to the Representative Assembly. He has served on the Council of the College of Physicians and Surgeons of Saskatchewan since 2011 and elected as his second term as president specifically to assist in overseeing the transition of the leadership from the current registrar, Dr. Karen Shaw, to Dr. Grant Stoneham, coming in July. So Dr. Beggs will be providing the CPSS update today. Thank you.
Thanks very much. Good morning, everybody. I think I'm the only sucker here in a tie this morning. And I'm at high risk of going down the same road as Mike Kelly yesterday, so you'll excuse me if my voice explodes. So again, thank you very much for the time. This won't be sort of a conventional report as to going through the bylaws, etc., that we've been working on in the last year. You can all breathe a sigh of relief because there are many of them that we've been working on, and it's many works in progress. So initially, obviously, this is a transitional year for the college in many ways. I won't repeat Dr. Jeffrey's kind words for Karen. She's well aware of our feelings about her. And we would like to welcome, obviously, Dr. Stoneham, who's currently, I think, recovering from COVID, to join us as the new registrar coming in, and we're very happy to have him. But that is a large transition for the college, and so obviously there'll be some changes afoot that'll keep us busy over the course of the next 6 months to a year. We can touch slightly in the questions if you wish to on the normal work of council. There are obviously a number of things that are constantly at play, and they're evolving through council work with respect to bylaws and policy. We continue to work on our strategic goals, the four main goals that we have had in our past strategic plan, and we'll be updating that in the not too distant future. And we've been very successful in meeting the goals of, or meeting our objectives of marching along with those strategic goals. There are a number of policies and bylaws that are in play right now that are, germane to this very interesting time across the national stage. Obviously, we're talking about physician's assistants, as is the SMA, as is government, and that'll be a new and evolving practice within your own practice groups and throughout Saskatchewan over the next little bit. Certainly, there's a tenure of physician's assistants in North America and in Canada, but the role that they will fill has yet to be determined and will certainly be evolutionary in how we practice medicine, both in the community and in specialty centers. Practice coverage as a policy has garnered a great deal of interest from the medical population at large, and so obviously we continue to look at that to make sure that it's the best thing for the public, while also being something that's facilitating your practice, or at least working not to hinder your practice. And then there's a lot of movement afoot, obviously, with respect to increasing the accessibility of licensure in various different avenues. One of the avenues which we're looking at very closely is Canadian trained physicians who have exhausted their eligibility for either CFPC or Royal College certification, and how we are going to look at those and work with those physicians. Traditionally, that has been an end of the line phenomenon, and across the country that's evolving, so we of course are evolving with it and trying to figure out ways that we can deal with workflow and human health care and health resources issues while still adhering to the need for standards. You have to excuse me, I'm reading off my iPad here, and I'm a terrible iPad user. My daughters would be ashamed. When we look at the, the areas of the college that people don't really love to chat about too much, obviously discipline, we know that complaints are up. Complaints are substantially up year over year. It's unclear whether that represents the fact that physicians are, wandering off the beaten path of their own in higher numbers, or whether it is a higher sense of advocacy on the part of patients, or a combination both. What we do know, however, is that due to the good work of Dr. Oberholzer and his crew, both in quality of care and complaints, the time to resolution for these issues is dramatically better than it has been in past years. The legal team does a phenomenal job for us at the college and works very hard to help physicians and to make sure that the resolutions are in everybody's best interest, particularly the patients who we serve. I'd like to sort of turn my attention and the attention of this talk a little bit more to the national stage and to look across the country, because that's really where things are evolving at a fairly rapid pace. I think it's fair to say that the bulk of physicians in the province and in the country don't spend much of their time really paying attention to regulation of medicine. It's assumed that we work in a self-regulated profession, and it's assumed that those processes work in the background, and we pay our fees and we get our licenses, and hopefully we stay on the right side of those regulations for our whole careers and all goes well. But as we look across the national stage right now, we see that we're in a huge transitional period. Self-regulation of medicine is, without being overly dramatic, in a bit of an existential crisis across the country. We can look west to British Columbia, where the government has put in sweeping reforms in self-regulation across all licensed professions, not just medicine, all self-regulated professions. And we're seeing huge changes in the way transparency works and the way oversight is now being delivered predominantly by non-physician-based oversight committees. And I think we can all agree that while having patients as a part of the oversight and regulatory process is essential, because we serve the public. It also gives a very different flavor to the interpretation of how concerns and complaints and quality is interpreted, because they may or may not have the background in medicine that we would all be expected to have were we reviewing the same sort of concerns or complaints. Not a bad thing, but a very different thing. And we have to see where things are going to go with that. Now, the government of Saskatchewan has been quite clear to the council that they have not been looking at significant regulatory change. However, things change. So it is worthwhile for the membership of the college at large to start paying attention to the national stage. And certainly as a member of the SMA, I would strongly endorse that our organization continues its good work in maintaining an eye towards the regulatory perspective, not only the advocacy perspective that they do so well. When we look at other things on the Canadian stage and the national stage, obviously pan-Canadian licensure, national licensure is a major issue. It's very much in the political eye right now and getting a lot of play in that regard. But, excuse me, I think we can all agree that anytime we change the approach to licensure, the devil's always going to be in the details, as with most complex processes. At the end of the day, licensure is a constitutional issue. The provinces have a mandate to deliver health care and to regulate the health care. But pan-Canadian licensure, or single licensure across the country, is going to involve a degree of collaborative change across the provinces that has never before been identified. Changes in legislation that will have to occur synchronously and similarly in context. And that is something that the Canadians have never, ever seen. So it's important to remember that in order to achieve these sorts of pan-Canadian licensure changes, there has to be pivotal change at every single province and territory at the same time, and also at the federal government level with constitutional changes. So magnificent legal changes to achieve. If we're talking about the single licensing bodies, no one is really sure how that will evolve. We all know that we have provincial licensing bodies now. Where would a national license come from? Who is the national licensing body? Will the colleges exist, or will this morph into some other form of FEMRAC, our national regulatory collaborative, which is by no means a body with the power per se. It's an advisory body to the colleges. How will that evolve in the future? These are all questions that you really do need to avail yourself of, particularly if those organizations migrate out of the province. And, you know, if it's a national organization, we would expect it to be centered in Ontario or somewhere in Eastern Canada. How does that affect your rights and abilities and practice pattern in Saskatchewan when it's governed from a national stage? In the event of complaints and concerns, which, as we all know, are going up numerically for the reasons I've already talked about, who is the regulator? Who's going to help you and your patients work through those problems when, in fact, the licenses are being presented on a national stage? And I'm not for a minute suggesting that national licensure is an error or a bad thing. We just have to look at it very, very carefully for the unintended consequences. So when we're talking about the national stage, as opposed to Saskatchewan specific, we need to try and fill out what needs are we trying to fill with this process, because there's no question that there are needs. But I think we can all argue successfully that the needs in Saskatchewan are different than the needs in Ontario, the needs in Quebec, the needs in the East Coast. And certainly the needs in Saskatoon are different than the needs in Watrous and the needs in Swift Current, the needs in Regina. So everyone has their independent needs, and so we have to make sure that the legislation and regulation is in tune with that level of need, as opposed to the more global need or generic one-size-fits-all needs. Are we trying to work towards increases in access, or are we trying to work towards increases in capacity? Two very commonly synonymous terms that are not at all synonymous. They speak to very different concepts of patient care delivery. I can go get my hip done in Alberta because they have capacity. We have access here. They have access there. If I go get my hip done in Alberta, I'm taking away Alberta capacity, even though I may be increasing Saskatchewan access. So there are different concepts that need to be approached differently. We need to look at people who are, what are the advantages and conveniences to practitioners? Underserved communities, northern communities, locum opportunities. These are areas in which national licensure is going to play potentially a hugely valuable role. However, that represents a relatively small population of physicians migrating across the country, or a very focused level of patient care. And we know from looking south of the border that when we look at the interstate compact on physicians being able to migrate between one state and another state, even though there's a huge number of physicians in the United States, this actually only impacts a very, very small percentage of the physicians. It has not been widely taken up. And they face, in many jurisdictions, the same needs that we face with respect to underrepresented populations, underserved populations, need for cross-jurisdictional locums. So it's important to understand that we're potentially changing the system to fix what is a situation that will only impact a few physicians and some very underrepresented patients who definitely need those changes. It's important to know that many people in this this environment of trying to go extra-jurisdictionally, the administrative problem is at its very bottom, the licensure fee. We all know that nobody likes to pay professional fees, but we all know, both from the SMA and the college, that those fees don't just go to writing your license out. They fund organizations that serve many other roles for the public and for you as the physicians. So if those fees go away to a national licensing body, how does the college or colleges or whatever those morph into or iterate to, how do they then run the business of regulating medicine without their primary generated income? So it's conceptually challenging, particularly when we're talking about the fee difference being a relatively negligible part of our combined take-home pay at the end of the year. But nonetheless, fees are fees and we all hate them. When we look at recruitment, which has been mentioned here, extensively, as it well should be, it's a major priority, and it's also a major interest to the college, of course. There are existing models of expedited licensure all across the country. There are registrars all across the country who have specific powers to change licensure, expedite licensure, facilitate specific case-by-case licensure issues. So those models exist as it stands right now. So it's important when we talk about expediting licensure as a general principle that we approach this in a very even-handed level, so that we know that expedited licensure does not result in altered standards for the physicians that we are inviting into the community, whom some of you are kind enough to supervise through CIPR programs or other programs, and enter into care. We know that right now in Canada, jurisdictionally, there are modifications to enduring licensure that are occurring at a never-before observed rate. In the news, of course, we've all seen from Nova Scotia. They seem to be the poster child for doing this without chatting with any of the rest of us. And there's always been changes across the country, as is the college's right independently. But now we're seeing pivotal changes in licensure, changing examinations that before now were considered to be absolutely essential to assume basic medical knowledge, basic English language competency. These changes are happening on a very independent college level, whereas we used to work very collaboratively as the college. We're seeing now envelopes and bubbles of colleges working a little more independently. We see the East Coast group working together. We see Ontario working on its own, Quebec working on its own. It hasn't affected the western end of the country quite so much, but these are evolutionary times, and it really behooves us all to pay attention to what's going on and to be able to stand up and say, potentially this has some unintended consequences that could affect us down the road. We look at the Halifax now willing to accept American Board certified physicians direct into practice. Arguably, if you're an American Board certified surgeon in New York State, you're perfectly safe to operate in Halifax. There's no question of that. But the rules have been applied across the board thus far, and now we're picking and choosing, according to need, whom we apply these specific rules to. And that opens us up to a great deal of other concern with respect to the specialties that maybe aren't in greatest need, wanting the same efficient and effective changes applied to them. How do we say no? We're also looking at internationally educated physicians. What are the rules for coming to the country and joining us in medical practice? There's always been a lot of debate regarding the qualifying exam number 1 as to whether or not it is the exam we should be using, whether it's fair to apply that to someone who's been in specialty practice or established general practice and family practice for a decade or more. Is it fair to ask them to write or qualify at what is, basically your graduating from medical school type exam? And while these are all valid questions, it provides a standard, and that standard is something that's very hard to wash away. Should we evolve? Arguably, we certainly are evolving and looking towards evolving further, but we have to evolve at a rate that provides safety for everybody, and we can afford to install standards. The unintended consequences, of course, I'm not going to go through a million specific case scenarios with you. Nobody wants that on a Saturday morning. But I think it's important to know that as we evolve differently in different jurisdictions across the country, the Agreement for Internal Trade in Canada opens up a huge door for internal migration that may or may not be beneficial to us as a province. So if you're coming in from a country that previously could not qualify for direct licensure, and if Halifax really needs doctors, and if Halifax decides to give them an unrestricted license based on their new criteria, according to the Agreement on Internal Trade, they can pick up and move the next day. That may help patients. That may bring care to other patients and increase both access and capacity. But a physician who yesterday wasn't qualified to work with you in your practice in Weyburn or Watrous, Swift, now will be in your practice, possibly even under your supervision for 5 years on an unrestricted license, because that's the law. We have to give it to them. So there are changes afoot that really do warrant significant oversight and watchfulness, not just on the part of the colleges, but also on the part of regulatory authorities, advocacy authorities. It's obviously center stage with the CMA. We need to just pay attention to what's going on in the background. And that's really the gist of my talk today. So by no means do I want you to interpret this as a pan-Canadian licensure is an unbridled evil. Absolutely not. This has the potential to really help patients in underserved areas. But like all things we do in our practices every day, be that a procedure, delivery of a medication, counseling a patient, we do it based on observation. We look at the evidence. We do it carefully and conscientiously, and we move forward together as a group so that they're not doing things differently down the road than we're doing in our practices. And I think the same is true of regulations. So with that being said, I hope that you can take this back to your home practices and collegial groups and ask them to look towards the national stage, make sure they're aware of what's going on. We certainly will be sending out regular notification from the college as to substantial changes. Obviously, anything that impacts the way we regulate within Saskatchewan as a self-regulating body will be put out to the membership. So with that being said, I thank you for the time. I hope I haven't run over, but I'm happy to field any questions as long as they're not too complicated, because it is a Saturday morning and I'm strangled in a tie.
Thanks so much for that thorough report. Some of the things that you touched on do come up in conversation a lot in laboratory medicine as well too, so I'm glad to see that we have some questions for you. I'll start with microphone number 1. Please introduce yourself and let us know where you're from.
Dr. Ade Digi. I'm from Weyburn. Thank you, Dr. Beggs, and nice talking to you through Bedline all the time. Every time I need to transfer patient, it's always him on call. Anyway, quick question 3. Number 1, for the physician assistant, my colleagues have been asking because we are likely going to be getting one of those. So the first question is, are they going to be regulated by CPSS being the, just like, how do I put it? Like nurse practitioners, right? They have separate regulatory body. That is one question. Number two, are they going to be to be covered, insured by CMPA? And number three, the reason for that is the supervising doctors are asking what will be their liability and their, insurance coverage. That's the reason they are asking. The other thing is, are they going to be will they take membership in SMA? Thank you.
Okay, so those are 4 questions. I'll try and work through them here. But, you might have to repeat one of them. So first question is, yes, physician assistants will be regulated via the college through the normal processes of the college. So their licenses will be obtained through us, and those bylaws have already been passed on to government. Have they been vetted? No, they're not yet vetted. So, but they're in the government's hands. Our work in that portion of the work is done with respect to licensure. The other questions I may not be able to answer fully. CMPA, whether they'll cover them or not, well, Brian's shaking his head, which I would take as an answer no, so they'll be independently insured. Now, there are physician's assistants in Canada already, so there's a process presumably that they will have access to. They're not like nurse practitioners in the sense that those are governed by the SRNA, the College of Nursing Professionals? College of Registered Nurses, sorry. With respect to supervision, the liability is a bit of an obvious question. These are directly supervised individuals. So as a directly supervised individual, you're responsible for direct supervision. And so you do bear culpability and liability with respect to how they're acting. Now, I don't know if Karen or Brian wants to clarify that further, but yes is the short answer. If there is a physician's assistant working and you are their supervisor, as there must be a supervisor, then you do bear specific supervisory rights. Am I okay to ask Brian to fill that in or no?
Yeah, that's fine.
Brian,
do you want to go to the microphone, Brian? Thank you.
Yeah, we had that discussion at the executive to executive meeting of the SMA and the college. And generally speaking, unless they are an employee, in which case you're liable. So it doesn't matter what the receptionist in your clinic does. If they do something that causes damage and they are your employee, then you are liable. So it's going to depend upon the nature of the relationship between the physician assistant and the physician. But if they are not an employee of the physician, then the physician is liable for what it is that they are expected to do, but not liable on the ultimate result. So that in a situation in which they are not properly exercising supervision responsibilities, and that's defined in the bylaws in terms of how many hours you interact with the physician assistant, but essentially the physician assistant is exercising their own independent judgment on a case-by-case basis and determining whether the patient should be treated by the physician assistant, the physician, et cetera. Having said that, the reality is that liability will be hard to establish, but anybody who's ever been involved in malpractice litigation knows you start off by suing absolutely everybody, even though you figure that you're not really sure who it is that may ultimately be liable. So my expectation would be in the vast majority of circumstances, if there is malpractice litigation, what you would have is the physicians being named, but probably not being found liable and maybe being dropped out of the suit once you get a little bit further down the road.
Thank you. Did we touch on all 4 of your questions? Thank you. Sorry,
Wonderful.
I'm an orthopod, one thing at a time.
Great. Microphone 2, please.
Great, thank you very much. I'm Ben Leese. I'm the section chair for internal medicine. So first of all, the CPSS was kind enough, and Dr. Oberholzer in particular, to arrange a special evening for specialists across the province who wanted more information about the CPSS coverage policy. And I thought that it was handled very well, and we really appreciate that the CPSS was willing to engage. I admit that apathy, probably on the part of specialists across the province not engaging with this policy over several years, might have contributed to a lot of the confusion around the coverage policy. However, there's a couple things that I think we took away from this that I wanted to highlight today officially. So first of all, I think communication as email as a primary mode of communication is not very good. I think generally speaking, being plagued with an email here and there, it's very difficult to know what's important, what's not. And I think we can all agree that our inboxes are full on a continual basis. And I admit Our relationship with the CPSS, as you rightly pointed out in your address, is we pay our fees, and if we don't get any notices of misconduct, then we go about our business. And I think that needs to change. I totally agree with you. So I think one thing that I would really like to see happen is that the CPSS engage very meaningfully with section chairs kind of on a regular basis. And I don't know what that might look like, or maybe even division heads, or maybe even community, based physicians, just so that that conversation is more ongoing. We know who the CPSS is, we can create more relationships and have more back and forth. The other thing that I was gonna ask you, and this kind of leads into my question, is one of the things that we've highlighted, I think, as specialists across the province, which I think is the main valid point, rightly or wrongly, this coverage of policy is in place. I have no opinion on it officially today. It's more that the lack of willingness to track the outcomes.
Just get you to ask your question, Dr. Lees.
So the question is, if we're going to implement change, what kind of logical metrics could one gather? Because we would hate to have policies implemented, especially in this existential crisis you're talking about, without tracking the progress and seeing, what are the unintended consequences of such policy changes. So could you speak to those potential metrics?
Yeah, absolutely. I mean, I won't go through sort of metrics to a degree that's going to be, statistically accurate here. But conceptually, you're absolutely right. If we put in a policy or a standard or a guideline that can't be policed, then what's the point of having it? I guess the balancing point is that we live in a complaint-based world. So down the road, when everything about a policy or standard is running effectively, we rely on concerns or complaints to come back to us to trigger us to look into this a little more closely and see whether somebody is in or not in compliance. And there's a process, obviously, that goes through Dr. Oberholzer's quality of care shop and then migrates as necessary either to an educational or discipline avenue. When we introduce anything like this, which is impacting everybody's policy and bringing people into compliance, what we then do is we then work through a process of going out and testing it. And that involves people at the college making phone calls after hours and listening to voicemails, listening to the service offered at your practice and what the message on the machine actually says. And then tracking, okay, how many of these people that we've randomly sampled are in compliance or out of compliance. If it's a low number, then we can deal with the low number specifically. If it becomes a more global number, well, then we have to work through a more educational process, which we do. I mean, Doc Talk is a very well put together piece of reading. I don't know that it gets a great deal of reading respect, but there's a host of information. And then we also have the avenues where if you don't feel that you're in compliance in your own practice, by all means, reach out. Because this particular policy has been, it's garnered a great deal of attention from the profession in very tight geographic areas, which is surprising. And we're willing to look at this. I think it's back on the agenda in June to look at again to make sure, did we hit the nail where we needed to hit it, or do we need to adjust a little bit, as we're quite happy to do. But if we feel that it's meeting the needs of patient safety and meeting our mandate as a college, then obviously we want everyone to be in compliance. It's surprising how, and don't throw things at me, the concerns, and valid concerns, have been very Saskatoon-based concerns. And I don't know if the specialist population in this northern half of the province are really vastly different with respect to the operations of their practice coverage than the south end. And it's been quite surprising to us. But we are continuing to look at it. It's on the agenda again in June, and we will continue to refine it as necessary, or send out information to ask you to refine your practices as necessary to bring everyone into balance for the protection of the patients we all serve.
Okay, thank you. In respect of our agenda, we will take the questions from the three people at the microphones here. Can I ask that you limit your question to under a minute, please? And I do recognize the observer microphone here, and I'm going to go 1, 2, 3 in order. So please, Dr. Lettingham.
Thanks. Thanks, Al. That was excellent. I'm just wondering what the next step might look like post QE2 requirement for mid-career specialists. Again,
I think that is in significant evolution across the country, and I don't have a good answer for you. I think the Medical Council of Canada as a whole is doing a lot of self-reflection as to what their role is. FEMRAC, which is the overseeing body, is not necessarily as collegial as it once was with respect to the registrars talking to registrars effectively. So the short answer is we don't know, but this is an evolutionary time where we are laser focused on how things are evolving and looking, because there's so much change interjurisdictionally, it's really a case of, okay, that worked well over there, so maybe we should look harder at what they've done. Is that something that we should apply? Or are we working as the gold model for others to look at? So I don't have an easy answer for you, but it certainly is high on the list of questions we all want an answer to.
Thanks.
Thank you. Microphone 2, please.
Hi, Francisco Garcia, Urology, Swift Current. Very short question. You spoke a bit to the rapid assessment where needed for some licensure situations interprovincially. Is there going to be any move towards different colleges not having to go back and re-verify all of those credentials from scratch like they currently still do, and more of a copy-paste from other institutions that have already credentialed and verified those particular qualifications? Because that adds a lot to the time, sometimes 3 to 4 months, when I've tried to go through that process.
Yeah, I don't think that there'll necessarily be a time where we wouldn't validate credentials, because at the very core of ensuring that we have physicians of a standard to practice is the credentialing, and there's a huge amount of variability in the credentials that are presented for validation. So I think if your question is if somebody is fully qualified in another jurisdiction and has had their credentials vetted there, yes, we would still vet them, but we would do that collaboratively. So I don't know that I don't know that we will ever come to a point where we do not vet credentials, because that's really our job. And I think that every patient in Saskatchewan makes sure that we want to vet credentials very carefully.
Okay.
So I do appreciate the time, and we're getting faster at it. Registration has improved their efficiencies dramatically.
Thank you. Please, the observer microphone.
Yeah, thanks for the opportunity to ask the question. I'll keep my comments and question under a minute. I'm Malik Lafontaine. I'm president of the Canadian Medical Association. I've talked lots about pan-Canadian licensure. Mm-hmm. Just to correct one inaccuracy, ministers across the country are not doing this because they just have decided to. In the bilateral agreements, they're required as an opportunity to access that funding to recognize credentialing across the country. So that is actually why. Second, I think we all recognize that the credentialing system actually doesn't work as a gatekeeper and as a complaint system. The majority of complaints do not get reported. I imagine every person in this room knows of a situation or has experienced a situation where they've tried to note a physician who maybe wasn't acting to standard and have been frustrated with people either not acting on it or being in trouble themselves as a result of them reporting that harm. So just to clarify, the system right now is not working. Now to my question. I get frustrated by registrars because these issues are not brought up around federal tables that we sit around. I think you've outlined it very, very well. I share all of them with you. If the registrars could come forward with a letter actually outlining how the system should be designed, I think we could take this conversation to a different place. What would you recommend as far as how to structure these national structures? Thank you.
Well, those are some broad-reaching comments. I'll respectfully disagree with your second point regarding with the effectiveness of the college discipline process. I don't think that we're in a venue at this point where in 2 minutes I could put down on paper how I would redesign pan-Canadian licensure. I think it needs to happen, and I think, as we both agree, I think it needs to happen collaboratively across the country. And the concern that we have right now is that it's not happening collaboratively. There's a large political drive towards pan-Canadian licensure to fill access, not necessarily giving due appreciation to the potential other trans-jurisdictional migrations that may occur. So I think it would be inappropriate of me to try to design the system ad hoc sitting here, but I think we can all agree 100% it needs to happen. It needs to happen with the appropriate people at the table, including the registrars, all the authorities and the associations that are advocating for medicine and for the people of the country. And that's a challenge because it's all managed constitutionally. And until that piece gets taken care of, the rest of us can't really redesign anything.
Great. Well, thank you for that robust discussion, Dr. Beggs. It's very informative. We're going to move on to I'd like to move on to the College of Physicians and the College of Medicine report and invite Dr. Smith up to the stage. Our dean has been with us at the University of Saskatchewan since 2014, and prior to that, having spent 5 years as the Associate Dean of Education at Dalhousie's University of Faculty of Medicine, and a highly regarded medical educator and administrator, completing both his undergraduate and postgraduate medical education at Dalhousie University, and is a fellow in the College of Family Physicians in Canada. In 2010, he completed a Master of Education in Curricular Studies with a focus on medical education and extensive experience in healthcare administration. He served as the Chief of Family Medicine, the Chief of Medical Staff, Vice President, Medicine for the Southeast Regional Health Authority of Nova Scotia, and recognized here for his strengths in developing relationships, collaboration, consensus building, change management, and a lifelong excitement about innovation and change. Thanks very much for being here, Dean Smith.
Thank you, and good morning, everyone. And note to self, I got to get my office to send out a shorter bio. Thanks for the opportunity to speak to you this morning. I really appreciate the opportunity to speak on behalf of the College of Medicine and report to you on our activities. When asked what are the priorities of the College of Medicine, I always say Indigenous health, equity, diversity, and anti-racism, and growth. And I'm going to try and cover those 3 areas quickly for you. Certainly, Indigenous health, we've seen a lot of progress in the last year with the appointment of Dr. Janet Tudousis as the interim Vice Dean of Indigenous Health. And she has worked diligently on establishing a Department of Indigenous Health. We have a search underway for a permanent Vice Dean of Indigenous Health. And just 2 weeks ago at the University Senate, the last step in the university process for approving new academic units was I was actually on vacation in Portugal when it happened, but I'm told it was a very moving ceremony and unanimous support, standing ovation for the establishment of the first Department of Indigenous Health in a medical school in Canada. So that was a big step. A lot more work to do on that file, as you all know. Equity, diversity, inclusion, and anti-racism are key priorities for the leadership and the college as a whole. You would have seen and can go on our website and see the Saskatchewan Human Rights Commission report on the state of EDI and racism in the College of Medicine. It's sobering, it's challenging. I don't believe that it's any different than any other organization out there, but I do believe, and I did believe that truth comes before reconciliation, that we as a college needed to know what our challenges were, and so they're out and they're for all of you to read. There's many activities, and I can't go through them all at going forward to address some of these concerns. One of those areas is a brand new admissions policy. So this class coming in August will be the first admitted under our new admissions. Dr. Trustin Domes has led that extensive community engagement, consultation, evidence-based approach to admissions. Really a big focus on admitting those people from Saskatchewan that we believe will stay in Saskatchewan. And again, that's evidence-based. We colloquially call it our Saskatchewan stickiness score, but it is part of the new admissions policy. Another part of the new admissions policy is changing our goal for Indigenous admissions from 10 seats to 20 seats, and that Indigenous admissions strategy is supported by an Indigenous admissions circle. So significant changes to our approach to admissions, and look forward to seeing how that unfolds over the next few years. Accreditation, you may have seen that we got notice. So normally when you get fully accredited, especially if you've had accreditation challenges in the past, you're required to provide follow-up data. So this past January, CACMS basically said, we're done with you. You are A1 on everything, and you don't have to provide us any further data. So that is actually the very first time in close to 2 decades that this medical school hasn't been doing follow-up on accreditation. But back at it, PGME accreditation is the first week in November, I think. I might have my dates wrong, but it is late this fall. So there is tremendous amount of work going on, and those program directors and faculty involved in all those committees, thank you. It is really a lot of work to prepare 30 programs for full postgrad accreditation this fall, but that work is well underway and led by Dr. Saxena. I'm going to talk a little bit about growth. Happy to say that we're adding 15 seats to the physical therapy program starting in August, which is a significant expansion. On June 1st, we will be submitting proposals to government for both OT and speech language programs in the province. I participated in a town hall or Zoom meeting with the OT and SLP community, as well as the Ministry of Advanced Education and University Senior Administration and my team. There was 110 people online. The OTs and SLPs across the province were just over the moon. I mean, they have every right to be a little jaded because they've been promised this in the past, but the presence of Ministry of Advanced Education, I think, really drove home that maybe they're serious this time, and we're excited to be trying to put those proposals forward. There's lots of renewal in our college. We're seeing a generational change in our scientists in both community health and epidemiology and the 2 biomedical science departments. And while we're thankful of all those scientists that have taught our science learners and our medicine learners for decades, as they retire, we're seeing it is literally a buyer's market out there for PhDs. There is an amazing recruits coming, and we're seeing, as soon as they come on board, they're getting SHERF grants, they're getting NSERCs, they're getting CIHR grants, and we're seeing big growth in our research productivity from our scientists. Nationally, as Dr. Beggs noted, there's a lot of change going on. There's 3 new medical schools in the works. There is expansion of undergrad and postgrad positions at every medical school in the country, with the exception of one, and that is Saskatchewan. There's new approaches being promoted. Queen's this year is going to admit a cohort of 20 students who will be admitted to family medicine as part of their admission to medical school. They won't go through CARMS. It's a very, they'll be, the admission process will be tweaked for this group. They'll have a different clinical experience. They'll all do their clinical learning as a cohort in one community. It is an experiment. Jane Philpott is very excited about the potential for this being a new approach. It allows you to tailor 4th year to the curriculum that often family doctors don't get in medical school by not spending all that time going to interviews and auditioning for residency positions. And it allows a very smooth transition from medical school to family medicine residency, and possibly the potential of shortening the time. So there's just one experiment. Toronto Metropolitan University, UPEI, Simon Fraser are all talking about their approach to training doctors is going to be generalism focused, primary care focused. And so a lot of change going on in the country on a medical education perspective. Growth, I mean, 60 seats added over the next 3 years in Calgary and Alberta, so that's 120 new seats. A big increase in their residency positions. 40 new seats in Manitoba, and over the next 2 years, an increase in residency spots. Jurisdictions tailoring things like our SIPA program, residency spots dedicated to Canadians studying abroad. Lots of innovation and ideas happening in both undergrad and postgrad medical education across the country to try and address this. We have been politely with the Ministry of Health officials, with the Ministry of Advanced Education, with our ministers that you saw here yesterday, saying we're ready, willing, and waiting. We are willing to look at different approaches to medical education, regional campuses. We're willing to expand, I think there's interest. We made a substantial presentation to the two ministries just last Monday, and they have, I think, listened and said, yes, we know we need to do something. So I'm hoping we'll see the opportunity for the expansion of enrollment in the College of Medicine. I want to highlight two leadership changes that I'm really happy to see. One is to see Dr. Mike Kelly take over as the department head in surgery. You all know Mike, certainly brilliant doc and scientist who's homegrown. His MD, his neurosurgery, his PhD, all from Saskatchewan. The other one is Dr. Pat Brophy. So Pat may be known to some of you. He is coming in in just 10 days as the head of pediatrics, pediatric nephrologist. From Regina, med school grad from Saskatchewan, did his peds in Manitoba and went to Mayo to do peds nephrology, and then spent the next 20 years in the States. He has been for the last 6 years the head of pediatrics and the CEO of the Children's Hospital in Rochester, New York. And he's one of those guys that you need a motorized vehicle of some sort to move his CV around. He's just a brilliant doc leader, and he's again one of the alumni, one of us that is coming back home to lead pediatrics, and I just think that is really, really exciting. So great leadership change in those two departments. We wouldn't do this without partners, and the SMA is absolutely one of those critical partners. Your programs for our students are highly, highly valued. Your support to us as an organization, highly, highly valued. Certainly CPSS, again, we work hand in hand with the CPSS in supporting our learners. SHA, obviously, that's where the vast majority of our clinical learning takes place, and we couldn't get this done without the SHA. 2,000 doctors in this province have medical faculty appointments. I like to, there's, if you count SIPA, undergrad, postgrad, there's somewhere around 800 people getting some sort of medical education in the province at any given time. I like to say to people that, probably on, any Monday morning at 10 o'clock, there's probably 500 or 600 doctors in the province interacting with the learner at that moment. You take it to Saturday afternoon, there's probably 100 doctors in the province interacting with. And you take it to 3 o'clock in the morning any night of the week, there's probably a doctor in this room, or 30, one of the doctors in this room, or 30 or 40 doctors around the province at that time up in the middle of the night interacting with a learner. If we didn't have you and your support, we couldn't have a medical school. So thank you.
Thanks so much. That's very encouraging to hear. We do have a couple of minutes for questions. I see a couple of people making their way up to the microphone. Great. We'll take those people, and then we do have to move on to the MCRC update. So just for the observer, I will prioritize microphones 1 and 2, but we will get to you. So please, Dr. Miller.
Sure. Thanks, Dean Smith. I just want to say I read the Sask Human Rights Council summary really quite closely. As a friend of a colleague that experienced significant discrimination within the college at the undergraduate and graduate level, it's more of a comment, but I just want to make sure that I hope this is more than just lip service by the college in terms of these EDI initiatives, because we really need to make sure that we have safe spaces for our students, and I hope it gets better.
Agree with you completely. I didn't talk about all of the things we're doing. Certainly, we have a task force of interested students, faculty, and staff leading a number of initiatives and lining up with the university initiatives around EDI. We are one of only 11 medical schools partnering with ICANN University in New York City on what's called Anti-Racism Transformation in Medical Education, a three-year project. We're the only Canadian medical school invited to work with that group. And then we've added resources in the Division of Social Accountability so that there's staff that also can work on this. I think one of our biggest challenges is data. Every organization trying to deal with EDI is faced with the challenges around data. We're also endeavoring to find new ways to collect data so we can actually see and document change.
And sorry, Christine, I should have come to you first, but microphone number 2.
Oh, no, that's fine. I'm Christine Ryan, North Central delegate. As one of the priorities of the College of Medicine is training physicians for all the people of Saskatchewan, and knowing that if residents spend time in places, they are both better able to understand those people, and they are also more likely to work there. Why have we not yet seen a mandate or an expectation from the College of Medicine that all of our residents will spend time in rural or regional centers?
So one of the pieces of data that I saw the other day is that of our students, the 18 students have so far finished a longitudinal integrated clerkship. And we would love to expand that program. That's a program where they do all of third year in Estevan, Melfort, Meadow Lake, or Larange. And so 100% of those students in the last 3 years matched, which is, of course, above the national average. So, and the other point is that 60% of them went into family medicine. So your point is right. This works. Part of our strategy includes so we have established an associate dean of rural medicine. So that's Tara.
Lee.
Dr. Lee.
Tara Lee, yes. Sorry, Tara. So there's lots of work going on there, and I know we're pressed for time, but agree with you. One of the things that I would like us to see do as well, and is see Royal College Specialties have additional requirement for a rural placement.
Thank you. I think that's absolutely necessary.
Okay, microphone number 1, please.
Hello, Dr. Carissa Brabant. I'm a U of S grad, and I'm a family doctor in Moose Jaw. I am an Indigenous physician, and I provide care for Indigenous patients from all across Saskatchewan who come to Moose Jaw for the Ranch Erlo Family Addictions Treatment Center. And many of my Indigenous patients from that center have said that my clinic is the first place that they have felt safe and welcome in a medical system. And so my question is, in line with the calls to action from the Truth and Reconciliation Commission, number 24, we call upon medical and nursing schools in Canada to require all students to take a course dealing with Aboriginal health issues, including the history and legacy of residential schools, the United Nations Declaration on the Rights of Indigenous Peoples, treaties on Aboriginal rights, and Indigenous teachings and practices. Is the college requiring these courses from their students?
So I need to confirm the details on this, but I believe that we are requiring everybody coming into medicine or applying to medicine to have taken a course in Indigenous health as part of their requirements to apply to medical school. All of our students take the practitioners' role in Indigenous health and wellness currently as a mandatory part of their curriculum. And there are additional curriculum being added in Indigenous health throughout the regular part of the curriculum. So lots of progress. Lots more needs to be done. You're absolutely right.
Thank you. Microphone number 2, please.
But well, you did remind me with your work in addictions that we are also put back to the growth thing. We actually, if you saw me talking with Peter Bott yesterday to the 2 ministers, it's because we will also be putting a proposal before government this spring to establish a division of addiction medicine. So again, another growth piece that we're working for, and that would include a fellowship year in addiction medicine available here in the province. So.
My name is Mateen Razi. I'm serving as the provincial head for anesthesiology. So I think all of us know the human resource challenges that we're facing in the province and across the country. I would like to advocate, and if you have any comments, I'd like to hear them, for the College of Medicine's support in the past with multiple initiatives, and I would like to advocate for further initiatives such as the establishment of a respiratory therapy school within Saskatchewan. So we're one of two jurisdictions that does not have it in Canada. And also for a SIPA equivalent program for specialists so that we can carry out assessments in a more streamlined manner.
Certainly can't argue with either one of those things. Mateen has led work on a SIPA-like program for anesthesia, and certainly is, again, another area where we can look to grow.
Thank you.
Thank you. This concludes the portion of the College of Medicine update. We thank you, Dr. Smith. Dean Smith.